do an adjacent level fusion. So oftentimes people have had a 2 or 3 level fusion before, and then we do a cervical disc replacement above or below it, and that maintains the range of motion. The question that's followed up by that is, after therapy, will the patient have any limited range of motion? And the answer is actually no. They actually have a hypermobility following a cervical disc replacement. The disc replacement provides probably a little bit more motion that's what's normally allowed with the cervical disc in your natural environment. So what I tell people is you will not lose any motion, and you will gain motion that's probably not perceptible. So it's a motion preserving procedure. Can this be done on the lumbar spine also? This actually has come from, this question is from one of our friendlier petitioner attorneys. So Joe Leonard here, I'm going to call him out. In the lumbar spine, the answer is it can be done, but the reality is that the data for the lumbar spine is very poor, and the procedure is much more morbid. You have to go in through the abdomen. And so in general, I don't typically offer it for my lumbar disc replace or lumbar patients, because it's not any better than a lumbar fusion, and it's probably more invasive. The data we have out of Europe now, which is 25 years old on the lumbar disc replacement, is that it's no better than a fusion, and most American payers have not authorized it as a result, and most surgeons in general don't do it on the lumbar spine. So typically a cervical spine promoting procedure. Another question is, what's the survivorship of cervical disc replacements? So now we have data in the United States at 15 years, and then we have European data at 25 years, and we've not seen any catastrophic failures. So unlike hip and knee replacement, which they have wear rates in 10 to 12 years, depending upon the life cycle of the spacer that's used, we have not seen any wear and tear issues, nor have we seen any debris issues. So at this point, we tell people it's probably going to last them a lifetime, and the reality is because we see lower pressures than the hip and the knee, and it's probably generating less wear debris, so it doesn't wear out. So let me ask a question to Dr. No and Dr. Verma. When do you think we will be operating again in some capacity in an outpatient environment? For a lot of people on the screen who have texted me actually, but have not messaged, they're asking in general, when do we think we can start seeing patients normally, and when can we start doing some type of procedural work? What's your best guess?
I think there's two different questions there. Number one is, when can we do it normally? And number two is, when can we do it? Again, everybody is cautiously optimistic, although I don't think any of us would go out on a limb and say we're out of the woods yet, but are cautiously optimistic that the early mitigation steps that were taken in Chicago has put us on a trajectory that looks like we'll be able to preserve resources, maintain hospital bed utilization, ICU utilization. So we should not get to a point like, for example, New York or some of the cities in Europe are experiencing right now, where it's just all out crisis and chaos. The second issue is then, how do we know when it's safe? And I think what we're looking for is what everybody looks for is kind of the growth of the virus and what they call the doubling time. So is how many days does it take before you go from 100 cases to 200 cases? And the second thing that we're looking at is the infectability of patients. So if you think about it, what happens when you get doubling is that one patient infects 2 or more patients. What we need to do is get to a point where one patient infects only one patient, so that the disease stays stable over time and you don't overrun the healthcare burden. How do we do that? We do that by a couple things. Number one is mitigation strategies, which we've been doing in extreme form, and will probably need to be continued in some form of less extreme form. And we also do that by early identification of disease, contact tracing, so that anybody who's been in contact with that person gets notified and tested, and quarantine procedures. So that's really the next step that I think we're going to start hearing governments, both locally and regionally and nationally, talk about, is what do we go to as phase 2, and how do we start doing some of those public health initiatives so we can start to open up aspects of society. I think everybody here thinks that the peak will probably occur somewhere in the next 7 to 14 days. And as long as there's not an overrun of resource utilization, I think by the end of this month, we probably can start to open up clinics, open up procedures in a limited basis to patients that are at low risk. So with appropriate screening, maybe younger patients, those without comorbidities. We'll have to do that again with lower volumes than we've done to date because we don't want waiting rooms packed with patients and packed with families. So I think to answer the second question, which is when can we get back to normal, that's probably more like a 12-week or more time frame. And it's going to depend on the ability for the government to put in place appropriate public health initiatives to be able to manage the virus going forward the same way that they've done in other areas in Asia.
And I just wanted to share, the Rush team has been very good in terms of providing analytics and monitoring their own data. Can everybody see my screen here?
Yes.
Yeah, so this is a chart of their general medical floor census. Blue are the number of cases that are coming in with COVID positive in the general medical floor. And the yellow curve is obviously the worst case scenario in terms of the exponential growth. And they are forecasting that they're going to be following more of this gray curve. So I think from a preparedness standpoint, they have, as Nick had mentioned, converting some of their regular floors into COVID floors. They're basically moving over a lot of the cases in the ER that are not suspicious for COVID to go into like a less extreme area. And then when they look at their ICU bed census, they also see a similar trend. You can see the blue is what their census looks like on the ICU setting. And the yellow is kind of the worst case scenario, and they're following more of that gray line. So I think from a resource bed capacity issue, they seem to be okay because they've really done a lot of work in terms of preparing for the surge. And so I think that is obviously a positive thing for the institution. Should we, we're getting to one. Do we want to keep going, or should we, consider tabling this, or what do you guys think?
I do see there's a couple questions that we didn't touch on. One from Ronnie and one from general user Gidget.
So let's do the general question first, which is to Nick and to Shane. If and when the COVID home tests are available and we find out that we ourselves test positive, do we call our PCP and report it? You're on mute. Nick.
I think we're a long ways away from having enough tests where people are going to be able to test themselves at home, particularly if they're in an asymptomatic state. As many of you may have heard, point of care testing is now becoming available. This is similar to the rapid flu test. So anybody who's had flu in the past couple of years, you go to your primary care office, they swab you, they put it in a machine, and 15 minutes later, before you even leave, you know whether you have flu or not. Those are probably the tests that are going to give us the best ability to control the virus going forward, because you can, for example, test people that are coming into the country, test people that have had exposures, and rapidly, rather than taking 4 or 5 days to identify somebody that has the disease, all the while they're walking around the community, is identify that same person within 1 to 2 days. And again, that's just trying to modulate that statistic that I was talking about in terms of how, if you have one sick person, how many people do they infect going forward? And if we can keep that as close to 1 as possible, then all of a sudden we have a steady state of disease that doesn't get to the resource burden that we're seeing now. So how that will work with public health, we're in a country where obviously we're a democracy and we've got a lot of restrictions in terms of data sharing and people having to provide authorization for data sharing. But I think what you'll see is apps or different programs coming out where, particularly if you're going to avail of sick time leave from your company or some of the benefits that are being added by the federal and state governments, that you're going to have to participate in these programs to help control the disease burden in order to be authorized to be involved in some of these benefits.
The other question is a case that's spine specific. Someone following a cervical fusion at C5-6 has continued pain complaints, and the pain physician is recommending a spinal cord stimulator. So this is based upon evidence-based guidelines for spinal cord stimulator placement. It's a significant step in the patient's care and treatment. There are indications for spinal cord stimulator placement, but they're very clearly defined and probably overutilized in our healthcare system, particularly in the workers' compensation and personal injury arena. So for this individual, I can't answer in general, but I would tell you a CT myelogram is in general obtained beforehand to see if there's any residual stenosis present from the surgery itself. If there is no spinal cord compression, then I would find it very hard to recommend a spinal cord stimulator. In general, the effects without any kind of anatomic distribution to the pain complaints and no residual compression of the cord would make a spinal cord stimulator outcome very poor. So I think we should, any other questions? I think, and then we can wrap it up probably at this point. We're at the 2 o'clock or 1 o'clock time period.
Yeah, so it seems like this was pretty well received from the people who were on the call. What we were discussing offline is that probably what would be helpful is to just reschedule for next Friday, noon to 1 again. We can provide you with an update on the data that we have regarding Russia census and projections going forward. And then Shane and I can also give you the talks on the hip and the biologics that we were scheduled to do today. Any last minute questions before we wrap it up? We appreciate everybody participating and being online. You know, we all often don't have, one of the silver linings here is there are a lot of things that we suddenly have time to do that we haven't had time to do in the past. And so I think this is a good way to connect.
Thank you, Dr. Singh, Dr. Verma, and Dr. No for joining. Everyone who was able to attend. I'm going to send out an email to everyone who received an invite. I know I got quite a few emails and texts about people and their work firewalls not allowing them to join because of Teams. So we'll have to look into that. But for everyone that is on the call, I will be sending out a copy of Dr. No's presentation as well as the Q&A recording. And I will send out another invite for next Friday from 12 to 1, Dr. Verma?
Yeah, I think that's perfect as long as it works for the other guys.
Okay.
Yeah, it works.
Yeah, works for me.
All right.
All right. Thank you, everyone.
Thank you guys.
Thanks, guys. Have a good day.